Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good afternoon, doctor. Thanks for seeing me. I guess the biggest thing lately is these headaches that just won't quit. Ever since I slipped in the parking lot 6 weeks ago and banged the back of my head on the concrete, I wake up every day with this dull pounding right across my forehead and at the back, like someone wrapped a belt around my skull. It gets worse if I bend to tie my shoes, or if the kids upstairs drop something heavy and the floor vibrates. I've been taking naproxen I had left from an old prescription, but I'm scared of running out or messing up my stomach.
I'm sorry you're dealing with that, Mr. Calderon. Take your time and tell me everything that's bothering you.
On top of the headaches, I've got this dry cough that's been hanging around 4 months now. It's scratchy, like a tickle I can't reach, and I sound like I swallowed gravel. I'll be up 4 or 5 times every night coughing, which just feeds the headaches. I was on ranitidine before, and it helped a little, but when they pulled it off the shelves, the cough came right back. I keep wondering if it's the lisinopril they have me on for blood pressure, or maybe all that asbestos I was around when I worked nights at the mill 18 years ago. I've never smoked, but it's still in the back of my mind.
That does sound frustrating. Have you noticed anything coming up? Blood, phlegm, anything like that?
Nothing. Just dry air, and my voice goes raspy by noon most days. My wife says I sound like I've been shouting at a hockey game.
All right, you mentioned dizziness too?
Yes, ma'am. It feels like the room's spinning even when I'm sitting still. If I turn my head fast, my stomach flips. I haven't fallen since the big one, but I stay close to the walls just in case. Tinnitus isn't really there, more like my brain's on a slow merry-go-round.
And your neck and back pain?
The fall tightened up everything. My neck's stiff every morning, and the low back pain I've had for years is worse. Sometimes there's a shooting pain down my right leg and a numb patch on the top of my foot. I used to push through and keep working, but now I'm unemployed and mostly stuck at home.
I hear a lot of strain in your voice. How are you coping day to day?
Honestly, not great. I had a seizure last July, missed my phenytoin for a few days and paid for it. Since then, I've been afraid to leave the house. Panic hits me out of nowhere. My chest gets tight, and I just hide in the bedroom until it passes. I used to do night shifts, which made pill schedules a mess, and I'm still trying to rebuild some kind of routine. My blood sugars are creeping up because I stopped the metformin and Actos when money got tight. So I test at home and see numbers like 160, sometimes 220. It all piles on and I end up stuck.
Thank you for sharing all of that. It helps me understand the full picture. Let me review what I've heard. and we'll tackle each piece together. Headaches and dizziness since your fall, a persistent dry cough and hoarseness, chronic neck and back pain with some radiating symptoms, anxiety and panic attacks, plus diabetes and blood pressure concerns.
That's all of it, yes.
First, about the headaches. Because they started right after you hit your head, and you're also dealing with neck muscle tightness, they could be cervicogenic or tension type rather than something inside the skull. Your neurologic exam today looked normal, pupils equal, facial muscles moving well, no weakness. That's reassuring. I'd like you to try naproxen, 500 milligrams twice a day with food for the next 2 weeks. Heat and gentle stretching for the neck can reduce muscle spasm, and I'm sending a referral to physical therapy so you learn safe exercises.
Sounds reasonable. Naproxen's helped before.
Great. Now the cough. Lisinopril is a common culprit for dry cough, so I'm discontinuing it and switching you to losartan 50 milligrams once daily. It works just as well for blood pressure, but rarely causes cough. To be thorough, I've ordered a chest X-ray to look at your lungs, given your asbestos exposure, and I'm arranging an ENT consultation for a scope of your voice box.
I appreciate that. My wife will be glad I quit hacking all night.
Next, your blood sugar. We'll restart metformin 500 milligrams twice daily and add a small dose of glyburide, 2.5 milligrams in the morning. I put in a request to get pioglitazone back for you pending formulary approval, since you did well on it before. I also replaced your glucometer strips with the correct brand. Bring in any unopened boxes of the wrong ones so we can swap them.
Okay, I can do that.
Your blood pressure today was 148/92. Borderline. Switching off lisinopril may actually help if the cough was raising your pressure. We'll recheck in 4 weeks when you come back.
All right.
Regarding the seizure disorder, your level last July was 7, which is subtherapeutic. I'm increasing your phenytoin to 330 milligrams at bedtime. We drew a stat level today, and I want you to pick up a weekly pill box so missing doses is less likely. If side effects like dizziness or gum swelling crop up, we can explore other anti-epileptics.
I've never used a pill box before, but I'll give it a shot.
Good. For the chronic pain in your back and knees, the physical therapy referral will cover core strengthening, and we'll revisit imaging if things worsen. Keep using naproxen cautiously, and let me know if you need a topical agent or lidocaine patches later.
Will do.
Your hepatitis C is stable, but you're due for surveillance. I ordered an alpha-fetoprotein blood test and a liver ultrasound. Those will be annual unless results change. I've also restarted simvastatin 40 milligrams at night to protect your heart, and you received your pneumococcal vaccine today.
Busy day for my arm.
Indeed, but important. Preventive care keeps you healthier overall. I've arranged a colonoscopy and a dilated retinal exam because diabetes raises eye and colon cancer risks. They'll call you to schedule. Meanwhile, I want you to try short daily walks. Start with 5 minutes to the mailbox and back. Movement helps mood and blood sugar.
I'll try. It's hard with the dizziness, but my wife can walk with me.
That's perfect. On the mental health front, we've restarted duloxetine 60 milligrams for anxiety and depression. It usually takes 2 to 3 weeks to notice benefit. You already have a psych follow-up booked for July 14th. They can adjust if needed. If panic attacks surge or you feel unsafe, call our urgent line anytime.
It helps to know someone's on the other end.
You're not alone in this. Before we wrap up, any questions about today's plan?
Just one, if the cough doesn't improve after stopping lisinopril, what's next?
Good question. The chest X-ray and ENT scope will guide us. If reflux contributes, we may add a stomach acid blocker again, though not ranitidine, but let's see what the studies show first. We can also explore inhaled therapies if airway irritation is found.
All right, I feel like we covered a lot.
We did, and you did a great job walking me through everything. Your next primary care appointment is in 4 weeks. Sooner if headaches worsen, you have a seizure, blood sugar drops below 70, or the cough becomes productive or bloody. My nurse will print your visit summary and medication sheet. Let's keep the lines of communication open.
Thank you, doctor. I actually feel hopeful leaving today.
I'm glad. Take care of yourself, Mr. Calderon, and we'll see you soon.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good afternoon, Dr. Patel. Thanks for squeezing me in today.
Hi, Mr. Wardell. It's nice to see you again. Please call me Maya. How have you been?
Well, that's why I'm here. I'm doing okay overall, but for the past 4 months I've been getting this wheeze at night. It's really strange. As soon as I lie flat in bed, I feel tight in the chest, almost like breathing through straw. My wife says she can hear me whistling when I exhale, and sometimes I wake up gasping. I prop up on 2 pillows and that helps a bit, but it's still there. If I roll onto my right side, it eases. On the left or on my back, it's worse.
That must be unsettling. Does anything seem to set it off besides lying down?
Tomato sauce, definitely. We had spaghetti 2 nights ago, and the wheeze came on within an hour after dinner. Coffee too. If I have a late espresso, I'll pay for it when I try to sleep. I've even cut back to 1 cup in the morning, and that's painful because coffee's my one indulgence.
I remember you saying that last time. Any heartburn or sour taste when this happens?
Yes, a bit. I can feel acid coming up at night, like a burn at the back of my throat. It doesn't always coincide with the wheeze, but sometimes it does. I wonder if it's all connected.
It could be. How about during the day? Any cough, chest tightness, or shortness of breath on exertion?
I walk on the treadmill most mornings. I notice I'm a little more winded than I used to be, but it's mild. If I push the speed up to a jog, I get that same tight feeling, but it settles if I slow down. I've been using my albuterol inhaler maybe twice a week, mostly at night before I lie down. It helps me catch a full breath, but the effect only lasts a couple of hours.
All right. Thank you for explaining that in such detail. Let's talk about your diabetes next. How's the home glucose monitoring going?
Pretty good, actually. My fasting numbers are between 95 and 115 most mornings. After meals, 2 hours after, I'm around 140. I haven't gone below 85, so no hypos that I'm aware of. I still take my metformin with breakfast and dinner, and the glipizide after breakfast.
Excellent. That consistency will protect you long term. Any changes in your diet?
I still avoid white bread and white rice, mostly whole grains for me. My wife baked cupcakes for our granddaughter's birthday last week, though, and I couldn't resist one. It didn't spike me as badly as I feared, so I'm pleased.
Life's too short to skip every cupcake as long as the numbers stay controlled. Now, about your cholesterol medication. You're still splitting the 40 milligram simvastatin tablet and taking half at bedtime?
Yes, 20 milligrams. I started splitting to save money, and it's been fine. I'm not sure where my LDL sits now. Last time it was 98.
We'll repeat a fasting lipid panel tomorrow. If your LDL is 100 or above, I'd like to move you back to the full 40 milligrams nightly. For people with diabetes, lower is safer.
That makes sense.
You'd mentioned your blood pressure spiked after a gym session?
Yeah, it hit 150/90 when I checked on the machine at the pharmacy. I ran out of atenolol and didn't realize until that morning. I'm still on nifedipine and hydrochlorothiazide, but I think the atenolol was smoothing the peaks.
We'll renew the atenolol today. Try to take it consistently. Sudden stops can let the heart rate climb, which is probably why your pulse is a bit fast right now.
I noticed the heart monitor here said 102. Usually I'm around 80.
Exactly. Speaking of vitals, we did a pulmonary function test in July, and it showed a mild obstructive pattern. That fits with your wheeze. I'm thinking some of this might be reflux-related asthma.
Is that why tomato sauce triggers me?
Very likely. The acid irritates your airway and can set off bronchospasm. I'd like to start you on omeprazole, 20 milligrams twice a day before meals, for about 6 to 8 weeks. If the wheeze improves, we'll know reflux is a key driver.
Happy to try anything that lets me sleep.
Great. Keep using the albuterol when you must, but let's see whether the omeprazole reduces how often you need it. While we're at it, continue propping the head of the bed or using an extra pillow. Avoid eating 2 hours before bedtime, and keep coffee earlier in the day.
Understood. I'll switch dinner to 6 o'clock and give it time to settle.
Perfect. Now, you'd asked about renewing vardenafil last visit, correct?
Right. It helped a lot with intimacy, but I want to be cautious with all these heart meds.
We'll order a PSA, comprehensive metabolic panel, and urinalysis tomorrow at 9 a.m. Assuming those are normal, I'll give you 2 20-milligram tablets today, with 2 refills pending your lab review. Take 1 tablet 30 to 60 minutes before intercourse, no more than 2 doses in a month. If you develop chest pain that feels different from heartburn or any erection lasting more than 4 hours, go to the ER straight away.
I appreciate that safety net. My wife will too.
I'm sure. Now, back to the statins for a moment. I want to highlight that even at an LDL of 98, research shows additional reduction with a higher dose translates into fewer heart attacks and strokes for people with diabetes. So if your labs justify it, I'll recommend the full 40 milligrams.
I trust your judgment. If it's just 1 pill versus half, that's easier anyway.
Exactly. We'll also check your HbA1c again. Given your meter readings, I expect you'll still be under 7%, but let's confirm.
Sounds good.
Do you have any foot tingling, visual changes, or new aches that worry you?
Feet feel fine, and I have my eye appointment in September. My knees complain after the treadmill, but I think that's just age and extra pounds.
All right. I'd still like you to schedule a podiatry check sometime this summer. Early nerve changes can sneak up before symptoms.
I'll book that next week.
Great. Before we wrap up, let me recap the plan so we're on the same page. Tonight, start omeprazole twice daily and continue the albuterol as needed. We'll refill atenolol. Please record home blood pressures at least 3 times a week. Tomorrow at 9, you'll come in fasting for labs, fasting lipid panel, HbA1c, PSA, CMP, and urinalysis. I'll give you 2 vardenafil tablets today with those refills depending on the results. If your LDL is 100 or higher, move to simvastatin 40 milligrams nightly, otherwise stay on 20. We'll see each other mid-July to go over results, adjust the statin, assess how the PPI affected your wheeze, and chat about the vardenafil.
That covers everything perfectly. Thank you for being so thorough, Dr. Patel.
You're very welcome, Damien. Remember, if you notice any chest tightness that feels different from reflux, vision changes, or severe shortness of breath, call me right away or head to urgent care. Otherwise, I'll see you next month with your lab printout and hopefully good news about your nighttime breathing.
Will do, and I'll keep the coffee before noon.
Deal. Take care and give my regards to your wife. See you soon.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Dr. Nguyen, I'm seeing cerebellar tremors in Mr. Lavoie after his first dose of Tributinib. The CT is clean, but the neurotoxicity is unexpected at this concentration.
That's exactly what worries me. His pharmacogenomics panel came back with a double null CYP2C8 variant. He's essentially unable to clear the active metabolite.
I thought Tributinib is mostly 3A4.
Usually yes, but the metabolite that crosses the blood-brain barrier relies on 2C8. Without it, the plasma level spikes 4-fold by hour 6.
That explains the drift in his finger-nose test. Do we hold the drug or attempt microdosing?
I paged pharmacy. They suggested we compound a 5 mg suspension and titrate every 12 hours while monitoring troughs.
Ethics will want in, this is off-label territory.
Already looped them. Their main concern is informed consent given the language barrier. Interpreter is en route.
We also need MRI to rule out paraneoplastic cerebellitis, but the titanium rods in his spine complicate that.
I reserved the low Tesla unit at the rehab hospital. Transport will take 90 minutes, so we've got a window to document and brief his family.
Good. I'll draft an addendum to the chemo protocol so the rest of the service doesn't repeat the standard dosing.
Thanks, Marco. Let's hope we catch this before it evolves into ataxia.
Agreed, I'll update you once the compound arrives.
Now look at question 26.
Tara, have you ever had a patient walk in with an experimental gastric stimulator still powered on during a CT scan?
Not until tonight. The radiographer called me because the scout image showed streak artifacts. Then the patient said the device had a rare earth magnet battery.
Great. And now the stimulator is stuck in continuous output, triggering diaphragmatic spasms.
I phoned the manufacturer in Osaka. They emailed an emergency firmware patch, but it requires a proprietary inductive coil.
We don't have that coil.
The rep checked their inventory map. There's one at the veterinary teaching hospital 40 kilometers south.
You're kidding. How do we convince them to loan it at 2 a.m.?
I already called their on-call anesthetist. Turns out she did her residency here. She's driving it up with a waiver form.
Good. In the meantime, the patient's potassium is dropping. The repetitive contractions are exhausting his stores.
I ordered 20 millimol KCl over 2 hours and started magnesium to stabilize the myocardium.
We also need to set the trauma bay to MRI safe mode. The coil has ferromagnetic shielding.
Facilities is on it. They'll de-energize the ceiling lift magnets before she arrives.
This has to be the most bizarre consult of the year.
Definitely. But once we flash the patch, the stimulator should revert to 3V pulses and the spasms will stop.
Let's prep consent and double-check ACLS drugs, just in case.
Already printed. I'll meet the anesthetist at the dock entrance.
I'll stay with the patient and monitor electrolytes.
Now look at question 27.
Laura, have you seen the radiation badge logs from last night? The gamma spectroscopy room registered a spike at 0317 that doesn't match any scheduled doses.
I did, Omar, and it gets weirder. The spike coincides with a pneumatic tube delivery that never reached nuclear medicine. The carrier vanished somewhere between oncology and pharmacy.
So we're missing 7.4 GBq of technetium-99m in a tungsten pig.
Exactly. Environmental health is already sweeping the usual drop points, but the RFID tag isn't pinging on any receiver.
Could the shielding have failed and blocked the tag?
Unlikely. That would require a full sheath collapse. I think the carrier jumped tracks when facilities rerouted airflow during the HVAC outage.
Then it could be sitting in an unused branch line, irradiating whoever walks past the wall.
I pulled the tube schematics. There's a blind spur behind the coffee kiosk on level 2, no shielding, lots of foot traffic.
Let's cordon it off and call security. I'll grab a GM counter and head there now.
I'll page interventional radiology for portable lead sheeting and notify the RSO so we can log potential exposures.
Good plan. Once we retrieve the pig, pharmacy will need a decay curve to see if the activity is still therapeutic or just waste.
And we'll have to complete incident reports for transport and radiation safety within 24 hours.
On it. Let's move before the morning rush fills that corridor.
Now look at question 28.
Dr. Patel, the ICU wants an ethics consult. Our ECMO circuit just hit its 27-day mark, and the only compatible oxygenator cartridge left is expired. I knew the supply chain was tight, but I didn't realize we'd burned through the last unexpired unit. We did, and the vendor's next shipment is held at customs because the silicone coating failed tensile testing. So we're staring at a choice: run the expired cartridge or cannulate for dual lung perfusion at a center 400 kilometers away. Transport says altitude changes could destabilize the clot that prompted ECMO in the first place. And the surgical retrieval team is tied up with a pediatric donor case. Earliest they could fly is 10 hours. What's the manufacturer's data on post-expiry membrane integrity? They issued a field bulletin. Efficiency drops 5% per month after shelf life, but no catastrophic failures reported up to 18 months. This cartridge is 8 months past, so theoretical efficiency loss of 40%. We could compensate by increasing pump flow, but that raises hemolysis risk. True, yet maintaining oxygen delivery at a 160 milliliter O2 min is non-negotiable. The patient's lactate was climbing even before this. If we choose to swap in the expired unit, we'll need family consent and full documentation that no viable alternatives exist. I'll speak with the family and loop in legal. Meanwhile, can perfusion prime the expired cartridge with bovine blood to stress test fiber rupture? Yes, they can rig a mock loop in the skills lab within an hour. If it holds pressure under 300 millimeter harangues for 30 minutes, we'll have some reassurance. Do it. I'll draft the ethics memo, and if the mock test fails, we escalate to emergency airlift despite the risks. Understood. I'll update you as soon as the test finishes.
Now look at question 29.
Ria, did you catch the alert from pathology? The histology AI flagged a possible prion pattern in that corneal donor sample.
I did, Jonas. And the donor's chart shows no history of neurodegenerative disease. If the AI isn't overfitting, we just accepted tissue that could seed variant CJD.
We already transplanted one cornea into the patient in OR2 an hour ago. Instruments from that case are in standard enzymatic soak.
Prion decontamination requires 1N-NaOH at 134 degrees Celsius for 18 minutes. The surgical trays can't tolerate that heat without warping.
So we either write off 60K of microsurgical lenses or risk cross-contamination.
I've paged infection control. They want serial Western blots on residual donor epithelium, but the lab's autoclave is booked solid with biohazard loads.
Could we courier samples to the provincial prion lab? They have the downdraft furnaces for confirmatory RT quick.
Yes, but courier flights are grounded. The wildfire smoke closed the airport.
Then we quarantine every ophthalmic set exposed after 8, tag them presumptive biohazard, and notify the patient's family.
I'll draft the disclosure letter and arrange MRI screening at 6-month intervals if the result comes back positive.
Thanks. I'll lock down the iBank freezer until we trace all other tissue from that donor lot.
Now look at question 30.
Dr. Singhal, telemetry picked up a rogue Bluetooth signal tunneling into the insulin pumps on Ward C. Someone's pushed unauthorized basal rate changes.
You're kidding. The manufacturer's firmware is supposed to whitelist only our hospital network MAC addresses.
A security researcher warned us last month the whitelist can be spoofed with a simple Stack Overflow exploit over BLE 5.1. Looks like someone's running it from outside the building.
Great. Which pumps were hit?
3 so far, rooms 372 and 325, all adolescent type 1 diabetics on hybrid closed-loop therapy.
Shut their wireless radios and switch to manual mode. Then get biomedical engineering to roll out the emergency patch.
The patch is still in QA. If we flash it without validation, we might brick the devices.
Then we soft reboot and force the pumps into USB-only diagnostics. Meanwhile, isolate the ward's Wi-Fi mesh and run packet captures to trace the spoofing source.
Network Ops is deploying a rotating frequency hop jam on BLE channels, but that could interfere with EEG telemetry upstairs.
We don't have a choice. Patient safety trumps continuous EEG data for the next 30 minutes.
Understood. Also, legal needs breach documentation within 2 hours to comply with Bill 17 cybersecurity reporting.
I'll handle the report once we stabilize glucose levels. Get Child Life on standby. The kids will panic when their pumps start beeping in manual mode.
Already called them. We'll have juice boxes and dextrose gel ready until the algorithm is back online.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Leah, thanks for sitting down with me. Our renal clinic is buzzing about the crossover benefits of SGLT2 inhibitors, and I wanted your cardiology perspective before our departmental journal club.
Happy to, Amir. Ever since Emperor Preserved and Deliver landed, everyone on the heart failure side keeps asking why we weren't using dapagliflozin or empagliflozin 5 years earlier.
Right, but nephrologists are equally sheepish. DAPA-CKD showed a 39% relative risk reduction in the composite of sustained EGFR decline, kidney failure, or renal death, yet I still meet colleagues who think these drugs are only for glucose lowering.
And what's wild is the mechanism. The tubuloglomerular feedback reset seems renal-centric, but in my HFpEF patients, the natriuresis and downstream preload reduction are what tip the scales. It's almost like we found a diuretic that moonlights as a metabolic modulator.
Exactly. The sodium delivery to the macula densa increases adenosine tone, constricting the afferent arteriole and dropping intraglomerular pressure. Meanwhile, in the myocardium, we're seeing shifts toward ketone utilization. Maybe the heart's just happier burning cleaner fuel.
Have you followed the case of Mr. Colin Reyes from our shared clinic list? 66, long-standing type 2 diabetes, EGFR 38 mg/min, 1.73, and an LVF of 48%. That puts him in that murky HFrEF zone.
Yes, he also had refractory albuminuria despite maxed out ASI and a mineralocorticoid antagonist. We started dapagliflozin at 10 mg daily 3 months ago. His spot ACR fell from 420 to 240 mg, and his weight is down 1.8 kilograms.
On my side, his NT-proBNP dropped from 1,880 to 1,050 pg/milliliter, and he hasn't been in urgent care once for dyspnea. The only hiccup was a brief orthostatic spell that resolved after we trimmed his loop diuretic.
That mirrors what DAPA-CKD hinted at. You may get an acute EGFR dip around week 2, but long-term slope flattening outweighs the transient fall. Did he experience that?
He did. Creatinine nudged from 1.9 to 2.1 milligram per liter early on, but it plateaued. I reassured him the dip was a hemodynamic artifact, not true nephron loss.
I love that you mention reassurance. One barrier I hear is prescriber anxiety. What if the GFR is too low? Yet the trials enrolled down to 25, sometimes 20 min.
Right. And the cardio community finally sees that the renal threshold is less about filtration and more about the drug's off-target benefits. Even in dialysis candidates, we're contemplating initiation for cardiovascular protection, though data are thinner there.
Let's drill into safety. My residents worry about euglycemic ketoacidosis, but the incidence was roughly 0.1% across the big trials. More common are mycotic genital infections, annoying but rarely dangerous.
Agreed. We give the hygiene talk up front. For heart failure admissions, I hold the agent if they're profoundly volume depleted or in acute MI, but otherwise I restart before discharge.
Speaking of volume, do you preemptively down-titrate diuretics?
If the patient's jugulars are flat and systolic BP is under 110, yes. Otherwise, I watch for rising creatinine or hypotension over the first week. What about metformin? Any dose juggling?
Only if EGFR dips below 30 milliliters per min. The British guidelines still allow metformin down to 15, but I get nervous about lactic acidosis in frail elders.
Fair. Another thing, have you noticed how patient-reported quality of life scores improve disproportionately to hard endpoints? Colin told me he can now mow half his lawn before resting, something he hasn't done in years.
That's been echoed in the Kansas City Cardiomyopathy Questionnaire data. Small but meaningful jumps in physical limitation and symptom frequency domains.
Switching gears. Any thoughts on SGLT2 inhibitors in IgA nephropathy? There's buzz from post-hoc DAPA-CKD analyses.
It's intriguing. Proteinuric reduction was similar across diabetic and non-diabetic cohorts, implying mechanistic benefits beyond glucose. We're awaiting the FLOW trial with semaglutide plus an SGLT2I for combined GLP-1 and sodium transporter blockade.
Polypharmacy nirvana or nightmare, depending on who you ask. But given the obesity renal cardiac triangle, I see synergy.
Let me throw you a curveball. HeFH patients on PCSK9 inhibitors, any contraindication to co-administering SGLT2I?
None that I've seen. LDL pathways don't intersect with sodium glucose transport. The bigger issue is pill burden and cost, but many provinces now subsidize SGLT2 inhibitors for CKD and HF indications.
Yes, Alberta's formulary expanded coverage last January. Cost conversations used to derail uptake, but now it's about clinical inertia.
Inertia is habit plus uncertainty. We have data, we need cultural change. I'm proposing a combinophocardio order set. When EGFR is 20/60 and LVEF is under 50%, the EMR suggests an SGLT2 inhibitor unless contraindicated.
Brilliant. We could bake in automatic reminders for ketone checks in 5 days if the patient presents with nausea.
And patient education videos, brief, plain language animations explaining why a diabetes drug helps the kidneys and heart even if you don't have diabetes.
Colin loved the analogy of turning down the faucet in the kidney while gently squeezing the sponge in the heart. He repeated it to his spouse verbatim.
Metaphors stick. Before we wrap, any lingering research questions on your mind?
I'd like randomized data in autosomal dominant polycystic kidney disease. The pathogenesis differs, but tubular glomerular feedback still matters. Also, longer-term glycemic neutrality. Some suggest SGLT2 inhibitors eventually trigger compensatory hepatic gluconeogenesis.
On my end, we need clarity on arrhythmic endpoints. Emperor reduced hinted at lower sudden death rates, but signals were exploratory. If SGLT2 inhibitors modulate cardiac ion channels via ketone bodies, that's a paradigm shift.
Imagine prescribing one drug that slows nephron loss, trims visceral fat, lightens heart failure symptoms, and maybe stabilizes rhythm. Not many molecules tick that many boxes.
And to think it started as a glycosuric curiosity in the 19th century Florizin experiments shows how translational serendipity can redraw disease boundaries.
Here's to boundary breaking. Thanks, Leah. Your insights will enrich our journal club discussion tomorrow.
Anytime, Amir. Let's keep blurring the lines between nephrology and cardiology for our patients' sake.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Good afternoon, everyone. I want you to picture a quiet Tuesday in my outpatient endocrinology clinic. Mr. Marwan Khoury, a 58-year-old mechanical engineer, sat in front of me with a puzzled smile. He had watched his fitness tracker count every one of the 11,000 steps he walked each day, and yet the scale barely budged. His body mass index was 38 kilogram M2. His A1C was inching towards 6.4%. And a recent echocardiogram had unmasked stage B heart failure with preserved ejection fraction. "Doc," he sighed, "I feel as if my own metabolism is gaslighting me." In that moment, I realized our entire therapeutic playbook for obesity had to be rewritten, because for the first time we possess drugs that do more than shave off a few kilograms. They rewire cardiovascular risk. 3 years ago, the SELECT trial asked a deceptively simple question. If excess adiposity is itself a cardiac toxin, can we neutralize it without relying on glucose as a surrogate? More than 17,600 adults with obesity, but no diabetes, were randomized to once-weekly semaglutide 2.4 milligrams. After a median of 39 months, major adverse cardiovascular events fell by 20% despite only modest baseline differences in LDL or blood pressure. That is the first obesity drug trial in living memory to meet a cardiovascular superiority endpoint with the primary mechanism being weight loss itself. I started Mr. Khoury on semaglutide. At month 6, he had lost 14% of his body weight, and his NT-proBNP quietly slid from 228 pdrim to 1 But what fascinated me most was his gait. He no longer paused on the exam room stairs to massage his knees. When we scanned his liver, the proton density fat fraction had fallen from 18% to 6%, suggesting that we were undoing 2 decades of steadily smoldering, non-alcoholic steatohepatitis. In other words, we were treating multiple organs with a single molecule. The story, however, did not end with glucagon-like peptide 1. Nature rarely uses one switch when she can install 3, and industry followed suit. Enter tirzepatide, a dual GLP-1 agonist tested in SURMOUNT-3. Participants first endured 12 weeks of boot camp-style lifestyle intervention. Only then did randomization begin. Yet tirzepatide still drove an additional 18.4% body weight reduction beyond the 5.5% already lost by diet and exercise alone. The implication is dramatic. Pharmacology can now amplify, rather than merely mimic, lifestyle change. Even that was not ambitious enough for the molecular chefs in Indianapolis. Retatrutide, a triple agonist that woos GIP, GLP-1, and glucagon receptors simultaneously, averaged 24% weight loss in just 48 weeks of a Phase 2 trial, numbers that edge curiously close to bariatric surgery. In some participants, the scale dropped by 30%, a physiologic moonshot once thought impossible outside an operating theater. Yet, as every clinician in this room knows, a trial is an echo chamber insulated from messy reality. A multinational real-world analysis published last week tells us that average patients shed barely half the kilos seen in trials, largely because insurance hurdles, supply shortages, and simple nausea push them to abandon therapy at month 8. Discontinuers in that cohort lost only 3.6% of initial body weight, compared with the 12% still insufficient to hit the glossy 15 to 20% figure on conference slides. Adherence, it seems, is the molecular agonist we have not yet bottled. The regulatory landscape is catching up. In December 2023, the FDA extended semaglutide's label, not just for chronic weight management, but explicitly to reduce the risk of serious cardiovascular events in adults with obesity who have cardiovascular disease. That wording may look like bureaucratic housekeeping, but it signals a seismic shift. Adiposity itself has become a therapeutic target, separate from glycemia. Let me circle back to Mr. Corey. 9 months into therapy, we repeated his cardiac MRI. The left atrial volume index had declined by 6 milliliter M22, and diastolic strain improved. He emailed me last month from a hiking trail in Banff. I finally trust my heart on an incline. For him, weight loss was never vanity. It was mechanical offloading of a myocardium swollen by years of silent afterburn. Where does this leave us? First, we must abandon the paternalistic paradigm that framed obesity as a mere failure of willpower. Second, we need to democratize access before the efficacy-effectiveness gap widens into the Grand Canyon. And third, we must remain vigilant students of physiology. As dual and triple agonists proliferate, so will questions about bone density, sarcopenia, and the neurobiology of satiety. Our task is to shepherd these molecules from the ivory tower into grocery aisles and public parks, where metabolic health is either nourished or neglected 3 times a day. I will close with what Mr. Corey told me during our last visit. When the weight left my body, it also left my mind. That is the intangible dividend of treating obesity as a disease. Patients reclaim cognitive bandwidth once hijacked by hunger, stigma, and fatigue. If we harness that dividend at scale, the public health payoff could rival any vaccine campaign of the past century. Thank you for listening, and may we all keep rewriting the script of metabolic destiny before it writes one for us.